everybody. Welcome to Health Impact. I'm here with Janae Sharp, and we're here for our monthly segment of 5 Good Things as part of Digital Health Talks. Hi, Janae.
Hi, how are you?
I'm good. How are the
I,
5 things?
well, I think some of them are really good. I also think some of them are full of controversy. So hopefully people will be able to weigh in. And as always, if you have good things, send them to us so that we can share. That can be like great success, great outcomes in your health system. Today, we're going to talk about some things in government, some things in reimbursement, and some things in health systems. So stay tuned.
Yes, and I will reiterate that if you have good things, send them to us, tag us, drop them in our LinkedIn, because that will save us time, because it took us a long time to find these 5 good things.
Right. Yeah, this week was interesting. One of the main good things, the first one that I thought of was the FTC banning non-competes. And the American Medical Association has come out in support of this for physicians and for some healthcare workers. Having a non-compete might mean that they have to switch jobs. They have to move areas because they can't work, they can't do their job anymore where they live. And so that was one of our good things, I will
Yeah, it's a
say.
bit, and it's controversial because, of
Yeah.
course, non-competes have been around for a long time. I don't think I really understood how they impacted doctors. I probably don't still understand them completely. Um, but I do know that a lot of doctors, and it sounds like the limits for who will be impacted is something like $160,000 to $170,000 for executives. So that feels like it's probably a lot of doctors, even those that are working in administration. And then I think it's also, there's a bit of nonprofit hospital versus for-profit hospital, and that they will, it seems within this rule, that they would be making exceptions for some of the nonprofit hospitals, even though they don't have jurisdiction there. So
Mhm.
I
Yeah, so
imagine there's going to be a battle ahead.
there's that question of if they're trying to expand their jurisdiction. Like, is that what the move is? So we've already seen a lawsuit replying. So you have on the one side, you have artificial wage suppression because people can't go work anywhere else. So they'll work for less or they'll work in worse areas. And then on the other hand, you have what you just mentioned. Like, is this a way to change the nonprofit status for health systems or to expand the jurisdiction that the FTC has
Mhm.
for
Right. And
employment?
so the Federal Hospital Association came out against it, saying, to some extent that it would, make it harder to employ doctors for those hospitals. So I think, well, it's a good thing for physicians,
Mhm.
hopefully a good thing for patients. Um, it could make it harder for hospitals, but I think it may also just show, sort of an evolution in how the hiring practices of physicians. But I'd love to have people on the show who probably know a little bit more about this than I do. But it does appear to be a good thing for the docs.
Yes. And maybe that's pretty telling that the organization representing individuals is for it and the organization representing the employers is against it. Even if no matter where it lands, I think this conversation is important, that
Mhm.
people are aware of the employment environment and also, kind of get that swift kick in the butt that you have to be competitive. You have to actually provide people with a great job. So,
Yeah, no, I think it is. I think it's a really interesting thing that a lot of people certainly aren't aware of in terms of, the decisions that physicians have to make when it comes to their jobs and where they work, and where they might be, be able to practice after they've been at a place for a long time. So super interesting. The other good thing that I think, both good for patients and for doctors, is around AMA's new codes that they're evaluating for remote patient monitoring that could come around in 2025. So, now when we have these discussions around RPM, there's a lot of question of what is going to be paid for and who's going to pay for it.
mhm.
Um, well, you can't pay for it unless there's a code.
Right, right. You can't. You can't bill for something unless you know what it's called. The interesting thing about these new codes is that many of them are related to remote patient monitoring. So in the past, remote patient monitoring was necessary to provide great care, but it wasn't necessarily something you were going to get paid for. There are several things in healthcare that people are doing already because they have to do it to give good care or to give appropriate care, but they are not being reimbursed for that care. So some of the new CPT codes do relate to remote patient monitoring. And I know you know a little bit, you know about remote patient monitoring.
Yeah, for sure. I had quite a few conversations about it today, in fact, in that we interviewed Joe Zakaria from Natera and talked to him about that. And, I've sort of been learning about it a little bit from them and obviously just doing the research, but it's interesting, it's been around for a long time, right? But it's changed. It's gone from what might have been you know, sort of arcade, older devices by the side of the bed that would, maybe do around medication adherence and compliance and things like that, and obviously blood pressure monitoring, but that the patient would have to take care of, and then it would tie into a system. And now we're looking at these devices that are, measuring vitals contactless with radar, and the patient has no involvement. But I also had interesting conversations around, both the payment model and the value. So depending on the type of care that's being provided at home, healthcare at home is part of a continuum, but it depends on what condition you have, to decide what that continuum is, right? So, but there's so much. It's such a huge world of possibilities, and I think, I've been thinking a little bit about kind of like the future state where,
Yeah.
in fact, we're, measuring our vitals on a pretty regular basis at home. And that could be really interesting and maybe a little bit too much for some of us,
Right.
health geeks,
Which
quantified
is,
selfers,
I
if
mean,
you will.
yeah, it's starting to happen now. We see people have devices that they love to bring with them. People love looking at their own data. Some people, you know, the people who
Hmm.
are athletes and the people who just really love, you know, a bad looking watch.
Right.
Um, I will say a few years ago, I was on a special interest group for the American Telemedicine Association looking at reimbursement for telemedicine. And it was very interesting talking to leaders about what could be reimbursed and what couldn't, and how the care that like asynchronous care didn't really have codes, like things that physicians and health systems are liable for and that take a lot of time weren't things that they could actually bill for. And I think it's great. Like, to me, this is great news. Like, you should be paid for the work you're doing, and we'll have a more accurate picture of what's necessary to take care of patients. So, great job.
Hmm. Yeah, no, it's important and it's good to see. And I think there have been strides with telemedicine. It's still not 100% there, and I think it's different by state and all of that. But I think, the dialogue is certainly happening and we're getting there, which is great. I think the other thing, speaking of payers, is a recent study shows that the rates of uninsured are lower than they have been in a very long time. And so I think maybe the lowest rate ever. And maybe there's a certain amount of variation between, I think Texas is something like 16% and Massachusetts is 2.4%. But the rate of Americans with insurance is at an all-time low. So maybe that whole ACA thing worked a little bit to get us coverage, you know.
Yeah, I think that's a great question. Again, we will be able to share some of this, the research supporting that. Some of it also looks at the disparities between who the haves and the have-nots. Like, why are some people insured? Why are some people struggling? And how those rates compare to life expectancy. People with lower access to insurance or to care, they don't live as long. And
Mhm.
it's also interesting that some of the southern states with the highest levels of poverty also have the highest levels of uninsured people. So there's a real question there for equity, to see if we're doing the work to ensure that everyone can live their healthiest life possible.
Mhm.
You know, being able to go to a physician, what is the percentage of people who don't go to doctors because they can't afford it? Like I think that's high,
Mhm.
right?
Yeah, no, for sure. And for what reason do you go? And then how do you go and how do you engage? And are you in an emergency room or are you going to preventative medicine and all of that? So I think a lot of that and the social determinants of health around it are super important. And the reasons why people aren't insured, vary across those demographics as well.
Yeah.
You
I
know.
think it's, more and more people are deciding to delay care or making decisions about their basic needs or their insurance with inflation. So
Mhm.
it,
Mhm.
it was surprising to me that it was so high. And I don't think
Right.
the health insurance system's perfect. You know, if anyone's ever called their insurance, I think they would agree with me. Um, or
Correct.
tried to find a physician in their area that actually takes their insurance. There are basic things that,
It is an imperfect system that we have
yeah, it's just
grown to
real,
accept, but without it, the healthcare system is a lot harder to navigate,
right,
unfortunately.
right.
Although,
Yeah, so
it,
that one with the good things, I was kind of iffy. I was like, oh wow, like it's still
Mhm.
really rough here.
It is, as with everything in healthcare, there are two sides.
Yeah.
Well, and hopefully with this one there isn't, and we bumped this one up to a good thing because it kind of ties into some of the things we've talked about with the administration's initiative around women's health. But recently, the Women's Health Access Matters and KPMG have initiated a partnership around $1.1 million to advance women's health. So that's just a continuing kind of cherry on top of good news where there's been some money and attention flowing to women's health and the needs there. So in speaking about the various needs across populations, that's another good thing.
Right.
Which what
That's a
that
that's a huge
today
thing
with
too.
Katie.
Like if we look at it, we have some of the lowest life expectancies for mothers of a developed country, and this funding is going to be helpful. It's also looking at research and investment and also ensuring that we have accurate representation of women in clinical trials, which
Mhm.
is critical. Being able to recruit the populations that drugs are designed for is going to be, I think it's great news.
For sure. Absolutely.
And we didn't have to fight about that. There's no real controversy in thinking
No,
about like
no.
let's,
Although I bet depending somewhere, somehow there is, maybe
yeah.
if the folks that didn't get the grant, the men, no, I don't know.
Yeah, I feel like
And
if men have a problem with
then,
it, just check in with yourself because
yeah, really.
that's wrong.
Um, and then our last good thing was the ATA conference is coming up, which I had the pleasure of going to last year. Where was it last year? San Diego, maybe? I forget. But I actually that's where I connected with Lygia from Ada Rose. That was super fun. Um, and this year it is in Phoenix. Is it May 4th through 7th? Am I wrong, right? Close.
It is. Oh, let me look. I clicked on the wrong page. I was just there.
But they
Okay.
have some great speakers. They'll be talking a lot, I bet, about that reimbursement around remote patient monitoring. They've been doing some great content for nursing and home health. Um, and so I'm excited to go there again this year and see everybody.
Yep, May 5th through 7th in
May
Phoenix,
5th through 7th.
Arizona. And we do have a discount code that we can share with everyone.
We do. Is it like Nexus 400?
I think so.
Yeah.
Yeah.
So, well, you'll
So,
have to subscribe and get the comments to get the code. It is in our monthly email, so you can subscribe to our newsletter and get that code. And then I will see you there. And then, of course, in other good news, we have our Health Impact Forum coming together really well for June 12th and 13th at Microsoft again in New York. We've confirmed a great lineup of speakers, and we have Natera Health is a partner, as well as SailPoint and Elite Groups and Microsoft and Nuance. And Dr. Sechin Jain is speaking from Scan Health Plan, and Dr. Komal Bajaj, who we heard from today, also speaking. So we are excited and getting ready for that.
Yep. We're looking forward to seeing everyone in New York and expanding our knowledge and also expanding the amount of people who are making an impact. So if you like getting things done, come. That's what
And
I
why
tell
don't you
people.
share a little bit, because the Sharp Index Awards are going to be there this
Mhm.
year again. Share a little bit about how that's coming along in terms of the nominees.
Yeah, we have some really great nominees this year. I'll share some of them. Let's see if I can remember their names. I will say Microsoft Nuance. Nuance has been a nominee and a supporter of the awards. And this year we're talking to advocates like Chase Anderson and also to leaders who are like Joe DiPiero from Mount Sinai, who has supported over, I think it's over 20,000 support visits for healthcare workers in New York. And some of the innovative projects and entire programs that have been stood up to support mental health for healthcare workers, they're huge. So the awards are our way of making it more popular to do the right thing for
Mhm.
healthcare workers. And, when you have a healthy workplace, patients are going to get better care. There's a direct correlation between that. So we get to talk to leaders, and I'm really looking forward to just recognizing and celebrating the people who are doing great work.
Yes, it
And
was such a great awards ceremony last year, and the people who did get win those awards last year are amazing, and the programs are amazing. So it's a wonderful and exciting thing for Health Impact to be a part of. And I encourage our listeners to nominate any programs that you know. When do nominations close, Janae? Do you have a
they will close at the end of May. So
great?
people have a while. And online, you can access like rubrics, like what we're really looking for. Also, if you know someone who's doing great work, let us know. There are a lot of people in this audience and in our network who are probably doing something to support mental health. That could be a technologist, a technology company that's really stepping up and reducing the workload. Wouldn't it be awesome if someday one of the EHRs won because they earned it? Like if we could make technology better, it'd be fantastic. So we would like to see some more nominations. So
Mhm.
you can go to sharpindex.org and awards and
And
nominate
great.
all
And
the
then
leaders we want to
yeah.
celebrate them.
Perfect. And you can subscribe to our newsletter, and we have the link in there every month. So for sure, it's such an important part of recognizing the community and the work that you guys do at the Sharp Index, as well as the work that our leaders out there are doing and encouraging that. So thank you. And thank you for joining me today, Janae. And thank you, the listeners, for joining us at Health Impact Live and Digital Health Talks. We are excited to talk to you again soon. Take care.